The next topic will be on newer lifestyle approaches to obesity, an overview by Dr. Muthukumar Jeyapul.
So the next speaker is Dr. Muthukumar Jeyapul. He needs little introduction. He has organized a few trendos in the past. He's an endocrinologist qualified in the UK, and he's the chairman of ARCA Center for Hormonal Health in Chennai. He's going to talk to you about the newer lifestyle approaches to obesity. Dr. Muthukumar.
Thank you, Kumar. Good morning, everyone. It's nice to be back and in Salem, and thank you for the opportunity from the organizers. My task for this morning is things have evolved in obesity management in the recent past, and things take a turn, seasons happen, and newer approaches become older approaches become newer approaches, and that's what we're going to look this morning. So we all are aware we've had an excellent introduction in the conference about obesity. We've spoke yesterday about increasing obesity, what are the causes and mechanisms. But the objectives for this morning is we are just going to target the newer lifestyle approaches in obesity, how to have a better grasp of things, what are the treatment options. We are going to look at very low calorie diets, or whether any special diets are applicable. Just to give you a broad overview, the prevalence is increasing every day, whether you take the USA or Asia or India, it's happening, and it's increasing in alarming proportions. Men and women don't have any differences in increasing prevalence of obesity, although women are particularly at an increased risk. Children too are not barred from this, and we're facing a pandemic in childhood obesity. The problem with India is wherever we see problems, we have increasing numbers. So in India, when you see obesity, then you're followed by a big population with diabetes and so on. The risk of obesity is higher, mostly in females, if they come from particularly an Afro-Caribbean background or Hispanics, smoking, lower socioeconomic status. This is a big problem in the Western world now, and we will be facing this sooner as well, because obesity as well as diabetes is starting to happen in the lower socioeconomic status strata of the population, and when this happens, the outcomes are very poor compared to when it happens in the higher strata of incomes. Higher fast food intake, increased time spent watching television, pregnancies is a risk factor, sleep deprivation, smoking cessation, and medications. When it happens, it leads to multiple diseases, as I've put here, and we are all aware of that. And then it goes on to lead to increasing diabetes. The more the BMI, the risk of diabetes goes many-fold. But what we are aware also is minimal changes in weight can prevent these complications of obesity. So if you just lose anywhere between 5% or 10% of your weight, then you have better chances of avoiding complications due to obesity. And this is the data which has been redrawn from the Look Ahead one, where when you lose 10% of your weight, then you're completely reducing your risk of type 2 diabetes. And what are the causes? Mostly, I would like to concentrate on the center part here. Our energy intake and energy expenditures are the most two common problems in today's world. Obviously, our physical activity has become so less that most of our individuals tend to spend very limited amount of energy on a day-to-day basis. Further on, then the risk regulators are cultural norms, environments where like software professionals have limited space in their work environments, psychosocial hazards, increasing depression, commercial messaging, poor knowledge and poor WhatsApp messages, HP access, and then you move on to the genes or your physical problems where you have metabolic issues, HP access problems, and other reasons. But at the end, your body weight primarily depends on energy intake and energy expenditure. And I'm not going to go into this, but there are multiple factors, both central from the brain and from the gut, which induce energy intake or regulate energy intake. The other problem with India is we have a very, very carbohydrate intense diet, which puts us at an increased risk of obesity. And where do we stand with recommendations? These are primary recommendations from the American Diabetes Associations, which tell us that diet should be individualized, as those they provide the same calorie restriction, but may differ in protein, carbohydrate, and fat content depending on the individual. And patients who achieve short-term success in their weight loss programs should be put on to long-term maintenance programs as they go along. It's just not a short-term therapy, but it should be continued long-term. Further on, any short-term intervention you put on a low-calorie diet or a total meal replacement should be prescribed by two selected patients by trained practitioners. So this is kind of very important, so that anybody managing patients with very low-calorie diet should have the qualification and the expertise to do this. And to maintain weight loss, you should incorporate comprehensive weight management counseling as well in these programs. And whenever you consider medications in diabetes, always make sure that you have medications which regulate weight gain or do not promote weight gain, and minimize the medications for comorbid conditions that are associated with weight gain. And sometimes your weight loss meds can be a good adjunct to diet, physical activity, and CBT. A patient's response to weight loss medications should be less than, if it is less than 5%, then these should be discontinued as and when appropriate. So what I'm going to talk about in the next few slides is appropriateness of lifestyle changes in these patients, and we know that these are the factors which continue to improve depending on the percentage of weight loss. So when we say lifestyle treatment, this is non-drug treatment in which an individual opts to engage or persist in regular activities to prevent, improve, or control a medical condition. And primarily we are looking at dietary patterns and content, activity levels, sleep quantity and quality, other behavioral habits. But the task is we are going to just concentrate on the diet changes which drive weight loss in today's world. And the components of the basic program include diet recommendations, exercise recommendations, and behavior therapy, and monitoring and follow-up long-term. And primarily all these factors needs to be addressed if you want to manage the patient long-term. So how do you assess a patient with their eating behaviors and so on? So the most important message or assessment what a person needs is their person's activity and diet, which are the two important medications what we use. And then the physicians are required to let a patient know which would be more effective and how long it should be done in this kind of chronic condition. So when we consider non-pharmacological programs, patients overwhelmingly regain all these problems when they discontinue and they don't have a long-term plan. So it is key that we follow this up long-term. Moving on to diets. When we mean by diet, there are multiple diets in the internet. Whichever you're comfortable with, we practice. And sometimes people say low carb, high fat, all sorts of things. We're just going to give you a broad overview of what we say is primarily we discuss diets as high protein, low fat, and so on. So in the left column, I've got here as Atkins diet, South Beach diet, carbohydrate addicts diets, and paleo. Primarily these diets limit carbohydrates, increase the protein, and sometimes fat also goes up. And then this Weight Watchers, Jenny Craig, specialty dietitians prescribing a particular kind of diet with these supplements, which are primarily low calorie, general levels of around 1,200. And then the other kind of cabbage diet and so on, where they use a particular food pattern to initiate weight loss. And you can pick and choose whichever you're comfortable with, but I'll tell you which has got evidence and which doesn't have. And primarily, most of these diets use your carbohydrate control, where you look at Atkins diet, where it is around 20 to 60 grams. Paleo is less than 60 grams, and very low calorie diets, which can be anything depending on the shakes you use. And carbohydrate addicts diets is primarily using lower glycemic index carbohydrates, and it's again restricted to less than 30%. And then there are fat-free diets and low-fat diets as well. But primarily, how do they work? They cause diuresis, so you have water loss. And secondarily, they mobilize glycogen mostly from your liver and your muscle stores. So you cause a weight loss about 1 kg per week, and then they generate ketones, and we have been aware that how ketones cause anorexic genic pattern, and they reduce intake of calories. So this leads to decreased calorie content. Appetite suppression can also happen, but unfortunately, primarily, these high protein diets, there is no data available for long-term usage. So that's where we stand currently. And they cause also dehydration, constipation, kidney stones, and sometimes these high saturated fat diets can also increase your LDL. They also primarily, they control low fruit intake, vegetables and grains, so thereby reducing calorie intake. And I'll just skip this due to time. But Weight Watchers is slightly a different thing. These are commercially available in Europe as well as in the States, and they offer their organizations primarily offering practical advice using group techniques, moderate protein, low fat, and limits refined sugar usage. And basically, you need to join these people, you need to pay a fee, and the fees is also tallied with the amount of weight loss. So if you lose a lot of weight and stay in the program, then your fees get chopped up as you go along. They primarily keep the patient in contact, they're structured, and they provide almost their structured meals with the fat content, and also sometimes provide ready-made meals offered to them. So when you come to all this, when you look at all the data, at the end of the day, the portion control remains the major part, whichever study you look into, is the crunch of weight loss. The other thing where things have evolved in the recent past is meal replacements. And when we talk about meal replacements, the newer data suggests that by including meal replacements in your diets, you can increase your initial weight loss, thereby you are kind of more successful in the initial few weeks of therapy. So currently, meal replacements are considered state-of-the-art dietary treatment for overweight and obese individuals. They produce double the weight loss initially than compared to traditional meal patterns. And what do we call as a meal replacement? It's any pre-packaged food product that is portion controlled, and mostly they provide for a single meal less than 300 calories, 20 grams of protein, up to 45 grams of carbohydrate and 9 grams of fat. And where do we find the data for this? And multiple studies have been done on these things, but the most important and the most recent has been the Look Ahead trial, which is a long-standing study on obese patients, which ran for around 10 years. And here, primarily, the weight loss at 1 year was directly related to the number of meal replacement the patient was having, and when compared to the normal lifestyle group. So it was thought that primarily more success was related to these meal replacements, which was used in the study. And the suggestion was to use more meal replacements or portion control diets to tackle obesity, at least in the short term. What happens when you provide your patients with a meal replacement? It offers portion control, calorie control, structured eating, so the kind of you're stuck with it basically. And most of these current nutritions, they have vitamins, they have a correct amount of protein and so on, so they offer fairly good nutrition to the patient as well. And stimulus narrowing, you can call this as whatever you mean. When you have a food full of plate, you want to eat more, but when it's a shake or a single flavored drink, you're not allowed technically to eat it. So there is a bit of stimulus narrowing here, and also you're not following, it is stimulus control in another way. How does it work? It's convenient and cost effective for most individuals, and that's one of the limited success on some of these meal replacements which are available to the public directly. Healthy alternative to skipping meals. They provide structure to an eating plan, reduces anxiety, and the compliance gets improved. So this is kind of primarily how meal replacements work. And they can also be used as a part of very low calorie diets. I'm sure people are aware of very low calorie diets, and this has again been in fashion many years since the 1930s. It went out of fashion after the last chance diet debacle, which happened in the 70s, where 50 people died in America, which was a very low calorie diet with substandard protein, and that's where it went out of fashion. So the last chance diet, which was used in the States, put this out of fashion, and now it's coming back again. But things have changed in the matter that we have got better meal replacement solutions, we have got good protein sources which are available now, and so on. So very low calorie diet is recommended for people who are 30% above their healthy weight. It offers 400 to 800 calories per day. It is mostly with low carbohydrates and high protein. It causes ketosis, and patients tend to use 3 to 4 pounds a week, but it requires careful physician monitoring, and there can be sometimes health risks associated with cardiac problems and gallstones. Most of these are commercially available with the names as given, and most of this is low calorie diet, around less than 900 grams per day, and they minimize loss of lean body mass, especially what is associated with weight loss most of the time. Both these diets, very low calorie and low calorie diets, needs complete medical supervision, and caution needs to be addressed. Most of these patients should have a higher BMI, looking for rapid weight loss. They need to be highly motivated, and medical comorbidities are stable. So if somebody has got type 1 diabetes, a recent MI or a stroke, cardiac arrhythmias, unstable angina, and other severe psychiatric illnesses or active cancer, they shouldn't be using these diets. What about maintenance? After losing 10% of their body weight, patients typically regain almost half of it over the long term, but this is where you need to really address things. And one study which has changed about low calorie diets is kind of the recently published direct study, which has addressed this typical question, whether these low calorie diets can be followed in the community. So this is a large, not a large study, around 300 people, done in the UK, general practices, and it was designed to address whether intensive weight management can produce sustained remission of type 2 diabetes in a primary care setting. So the inclusion criteria was type 2 diabetes within 6 years of diagnosis, fairly obese patients 27 to 45 kilograms per meter squared, and the endpoints were weight loss of greater than 15 kgs or diabetes remission as defined by a HbA1c of less than 6.5. And most of these patients were randomized, and there was a control group as well. And they went on a total meal replacement for 12 to 20 weeks. Food reintroduction was done after that, which slowly happened every 4 weeks. Step-up was done, and weight loss maintenance was happening around 52 weeks. And these were the significant results which was associated with the study. I'd like you to concentrate on the third bit of the study here, where drug discontinuation of diabetes was immense. So there was around 70% of patients who have completely stopped their diabetes medicine after this treatment at the end of 1 year. So these were highly impressive results, for people who are wanting more information, certainly they can go into and read about it. But these are the significant results. The weight was down, the HbA1c was down, and they were off diabetic medications long term. So what was suggested is a very low calorie diet can be initiated to initiate rapid weight loss in the community by trained nurses under the supervision of doctors, and this can be sustained over a period of time. So this is at least over a year. So this is quite encouraging, and almost half the patient in the intervention group did not need any diabetic medicines at the end of the study, which is quite impressive compared to all those things which was associated, what we have looked in the past. So high protein, low carbohydrate diet seems to produce a greater short-term weight loss. In studies, there was significantly a lower dropout rate when you compare a high protein, low carb diet. High protein, low carb diets produce favorable lipid changes as well in some of these studies. The cons really are the queries with regards to kidney function, questionable rationale, protein stimulates insulin release and so on, and the difficulty in following these diets long term, and some patients are put to risk of excessive or at-risk nutrients. So when you look at the other way around now, It's the high carb, low fat diet. It fits into most of the dietary guidelines issued by the societies. They are consistent with, they're fairly consistent with successful dieters. The cons are it produces gradual weight loss rather than compared to the high protein diets. It's a slow process, and it's associated sometimes with unfavorable lipid changes. And again, whenever you do any treatment for dietary changes for obesity, then you're at an increased risk of nutrient problems. So comparing low carb to low fat diet, weight loss is caused by a deficit in calories rather than the metabolic advantage of one another. Persons with the greatest calorie deficit lost the most weight. So if you stop eating, then patients lose weight. A very high protein diet may offer some advantages, perhaps in simplicity, limiting options, or increasing satiety. So many VLCD programs offer a high protein, low carb, low fat approach, and patients as such should be offered these kind of treatments under close supervision. But maintenance is the problem in our patients, and maintenance therapy is depending on your resources, whatever is available. And even in the look ahead study, the 4-year weight loss, people were starting to gain weight as the years go by. And what is associated, what are the positive factors associated with weight loss is physical activity. The physical activity should be more than 200 minutes per week at least. Diet and physical activity, counseling sessions they attended. So the more you're in contact with your medical professional or healthcare professional, then you're more able to lose weight. Consumption of meal replacements was also an important factor. This is another study where they looked at the different compositions of diet, carbohydrate, protein, and fat, and none of it actually mattered. And here again, the same data from the look ahead. The more you're in contact with the healthcare professional, you're more favorable for that. And there are some foods, if you're a person eating chips everywhere, then you're more likely to gain weight. And moreover, these commercial weight loss programs, due to time I'll skip it, are used for clients who are overweight and obese. Mostly these are available in the community and patients have to pay their health out of it, but most of the time you need to treat the patient when they're ready for weight loss. Where if they're not even contemplating about weight loss, then there is no point in striking chord with these people. So multiple issues have to be addressed: problem solving, contingency management when there is a stress management, cognitive restructuring, how we think about food, and so on. There are multiple factors in management of behavioral change. I'll just skip this. So pick your counseling tool. It should be a solution-based brief therapy. It involves motivational interviewing, personal improvement, and so on, and dietary and activity prescriptions. So in conclusion, obesity is a chronic disease influenced by multiple endocrine pathways. There are a lot of neuroendocrine substances involved in this. Structured lower carb, lower calorie diets are only effective in the short term. So you need to have a long-term plan for each and every patient. And also you need a behavioral therapy which goes along with your obesity treatments. Thank you so much for listening.